Brugada syndrome is a genetic disorder characterized by right bundle branch block pattern with ST segment elevation and T-wave inversion in right precordial leads. Life-threatening ventricular arrhythmias are the hallmark of Brugada syndrome. The disorder was described by Brugada brothers in 1992. First genetic abnormality detected was in sodium channel gene SCN5A. Later, several other genes have been implicated. Patients with Brugada syndrome may sometimes present with electrical storm. Drugs like quinidine and cilostazol have been useful in reducing the number of episodes of ventricular arrhythmia. Those with previous cardiac arrest, especially with a family history of sudden cardiac death, need to be protected by an implantable cardioverter defibrillator or ICD. Sometimes the classical Brugada pattern in the ECG may not be obvious and has to be brought out by flecainide challenge or challenged by other drugs. But challenge carries a risk of refractory ventricular fibrillation. Brugada syndrome ECG from one of our previous publications. I am always happy to see this ECG of Brugada syndrome as it was sent to me by Professor Joseph Brugada way back in 2001 for the inaugural issue of IPEJ along with his review article. Professor Brugada's article was the first ever article which I received for IPEJ, and it gave a great boost to the debut issue of the journal. ECG pattern seen in V1 and V2 with curved ST segment elevation has been called as type 1 pattern, while the saddle-shaped ST elevation 1 mm or more seen in V3 has been called type 2 pattern. In this ECG, there is Brugada-like pattern in anterior leads with a right bundle branch block pattern and an elevated ST segment. This is unlike the depressed ST segment in typical right bundle branch block. There is a leftward axis with RS complexes in leads 3 and AVF and a borderline PR interval of 200 milliseconds. Brugada-like ECGs have been described in various conditions with pathology in the region of right ventricular outflow tract like compression by a mass. Long QT syndromes are a group of inherited arrhythmogenic disorders characterized by prolonged QT interval and life-threatening ventricular arrhythmias. The prevalence of long QT syndrome varies from 1 in 5,000 to 1 in 10,000 in various regions. The initially described syndromes were an autosomal dominant Romanov-Ward syndrome and the autosomal recessive Jervell-Lange-Nielsen syndrome. Now it is known that both are two ends of a spectrum, with homozygous individuals having deafness due to defective endolymph secretion in the middle ear, which is mediated by potassium channels. Most common varieties of LQTS are LQT1, LQT2 and LQT3. LQT1 contributes about 50%, LQT2 about 35 to 40% and LQT3 about 10 to 15%. The other variants are quite rare, with only few families being described. A total of 16 genotypes, LQT1 to LQT16, have been described so far. ECG of a neonate with long QT syndrome. QT interval is 400 milliseconds and QTC is 520 milliseconds with a heart rate of 100 per minute. The term concealed long QT syndrome is used to indicate individuals with genotype of long QT syndrome and a phenotype with normal QT interval. They are usually detected on family screening of those with manifest long QT syndrome. The risk of sudden cardiac death or aborted cardiac arrest was 10 times higher in those with concealed long QT syndrome than the unaffected family members, 4% versus 0.4%. This was notwithstanding the finding that those with manifest long QT syndrome had a much higher risk of sudden cardiac death or aborted cardiac arrest at 15%. Congenital short QT syndrome is an inherited arrhythmic syndrome characterized by short QT interval and a propensity for life-threatening ventricular arrhythmias and atrial fibrillation. So far, 3 variants SQT1, SQT2 and SQT3 have been described. Though medical therapy with quinidine can lengthen the QT interval, implantable cardioverter defibrillator is the only viable option for prevention of sudden cardiac death. Shortening of QT interval can occur in tachycardia, hypothermia and hypercalcemia. Digoxin can also shorten the QT interval. These should be excluded before considering a diagnosis of short QT syndrome. Electrical alternans is a phenomenon seen on the electrocardiogram with alternation in the amplitude of QRS complexes. The term electrical alternans totalis is used when the amplitudes of all the waves P, QRS and T show alternating amplitude. Electrical alternans totalis is seen in cardiac tamponade and is thought to be due to the swinging movement of the heart within the pericardial cavity. Electrical alternans may sometimes be associated with its mechanical counterpart, pulsus alternans. ECG showing electrical alternans in pericardial effusion. Electrical alternans in pericardial effusion is due to swinging of the heart within the fluid-filled pericardial cavity. QRS amplitude is larger when the heart is in the direction of the ECG lead axis and shorter when the heart is away. Low voltage QRS complexes are noted with standard leads showing less than 5 mm of total QRS amplitude and chest leads showing less than 10 mm of QRS amplitude. QRS electrical alternance is very evident in lead V1 with alternate QRS complexes being smaller and larger. Close scrutiny shows similar changes in T wave amplitude as well. Alternance in P, QRS and T wave amplitudes is sometimes called as total electrical alternance, which is considered as diagnostic of large pericardial effusion. Sequential frames of two-dimensional echocardiography from apical four-chamber view shows swinging of the heart to either side so that the amount of pericardial fluid on either side varies with time. Such swings will produce electrical alternans on the electrocardiogram. ECG showing isorhythmic AV dissociation. In the ECG, P waves are clearly seen to be dissociated from the QRS complex. Atrial and ventricular rates are similar. Most of the P waves occur during the ST segment. An interesting clinical finding which can be seen in isorhythmic AV dissociation is reverse pulses paradoxes. In reverse pulses paradoxes, the pulse volume decreases during expiration. Here the pulse volume increases in inspiration because of increase in sinus rate which causes AV synchrony. During expiration, sinus node slows down and junctional rhythm take over, producing AV asynchrony. In a newborn infant, T wave in V1 is upright at birth. It becomes inverted within 48 to 72 hours as the right ventricle becomes unloaded as the lung starts functioning. The T inversion seen in children in anterior leads V1 to V3 has been called juvenile T wave inversion. It persists for a variable period into adult life, more so in females, and has been called persistent juvenile T wave pattern. In adults, the important differential diagnoses for anterior T wave inversion are myocardial ischemia and arrhythmogenic right ventricular dysplasia. This ECG of a 6-year-old child shows sinus tachycardia at a rate of around 140 per minute and T wave inversion in anterior leads suggesting juvenile T inversion. ECG in dextrocardia with situs inversus often has to be differentiated from arm lead inversion or technical dextrocardia. In true dextrocardia, chest leads will not show the usual ROA progression, while in arm lead inversion, the chest lead ROA progression is normal, provided the chest leads have not been reversed. Limb lead features are common to arm lead, that is left arm, right arm lead reversal, and dextrocardia with situs inversus. P, QRS and T waves are negative in lead 1, while it is positive in AVR. It appears as if AVR and AVL have been flipped. ECG in cartilaginous syndrome showing features of dextrocardia with situs inversus. P, QRS and T waves negative in 1 and AVL. Total QRS amplitude decreases as we move from V1 to V6 as the chest leads move progressively away from the heart, which is on the opposite side in this case. QRS axis is shifted to the right into the right lower quadrant instead of being in the left lower quadrant. Other features of cartilaginous syndrome are immotile cilia leading to sinusitis, bronchiectasis, and infertility. Tricuspid atresia is a cyanotic congenital heart disease. The hallmark of ECG in tricuspid atresia is right atrial enlargement with left ventricular dominance. Usually, in conditions in which right atrial enlargement is seen in a cyanotic congenital heart disease, right ventricle will be dominant. Absence of right ventricular dominance and presence of left ventricular dominance indicates that the right ventricle is diminutive, as occurs in a usual case of tricuspid atresia. The right atrial blood leaves through an obligatory atrial septal defect into the left atrium and then into the left ventricle. Left ventricle is enlarged because it receives both systemic and pulmonary venous return. If there is an associated ventricular septal defect, part of the left ventricular blood reaches the right ventricle and then into the pulmonary artery. In the absence of a ventricular septal defect, the whole blood is ejected into the aorta, part of which enters the lungs through a patent ductus arteriosus, which is essential for survival in such cases. ECG in tricuspid atresia. Right atrial overload is manifest as tall P waves in lead 2 and left ventricular hypertrophy with strain pattern is seen in lateral leads with tall R waves, ST segment depression and T wave inversion. The axis is leftward with predominantly negative QRS in leads 3 and AVF. The biphasic P wave in V1 with sharp atrial intrinsic arc deflection. The sharp downward deflection from the peak of the P wave to the trough of the P wave is a pseudo left atrial overload pattern seen in right atrial overload. In true left atrial overload, the atrial intrinsic arc deflection is more slanting, so that the negative component of the P wave is almost U-shaped rather than the V shape in this case. All these features together in a congenital cyanotic heart disease is characteristic of tricuspid atresia.